Finally, new hypertension guidelines. Not from the United States, unfortunately, but we are very fortunate to be standing here next to the co-chairperson of the ESC Hypertension Guidelines. This is Emeritus Professor Robert Fagard, University of Leuven, Belgium, and you have managed almost the impossible. You've gotten a new set of guidelines out here at ESC. You've got 2013 guidelines. What's the bottom line message at the very top that you have for these new guidelines?
Well, if you compare with the 2007 guidelines, if we start with blood pressure measurement, there was a lot of evidence on ambulatory blood pressure monitoring in terms of prognostic significance, but now we also have the evidence for home blood pressure monitoring. So we put them more or less at the same level, although they are not the same and they may have their specific indications. But home blood pressure monitoring has come of age, I would say. And that's important for white coat hypertension, for masked hypertension, etc.
What about levels of hypertension?
Well, for blood pressure itself, we have kept the same levels. So hypertension starts at 140 millimeters of mercury for systolic pressure and or 90 millimeters of mercury for diastolic pressure. But within hypertension, we have grade 1, grade 2, grade 3. Within normal tension, we also have 3 grades. And also of importance is the distinction with isolated systolic hypertension, because many of the elderly patients have isolated systolic hypertension.
Yeah, that was my next question, was about, we know from HIVET that it actually is appropriate to target high blood pressure in an elderly population. What are your particular recommendations in that group?
Well, the very elderly, as we call it, the octogenarians, that's new from HIVET. We also already had some indication from the Indana working group who looked at the data, individual data of patients of 80 years and older in other studies, and there was already some indication that it would be beneficial to treat them. But HIVET has confirmed that when you treat octogenarians, at least when they are in good physical, mental condition, we don't know about the frail ones, that when you reduce blood pressure from 160 systolic to between 140 and 150, that you can decrease total mortality, cardiovascular mortality, heart failure, stroke, so they should be treated.
Now, we're 10 years out from our last set of guidelines, and we talked about diuretics as first-line therapy and then adding on from there. ESC has almost always since then had a very different approach to first-line therapy. What do you say now regarding the drug therapy for hypertension?
Well, we did not change our position with regard to the 5 major classes: diuretics, beta blockers, calcium antagonists, ACE inhibitors and ARBs. So we feel that the decrease of blood pressure is the major thing, that most of them give about similar changes in blood pressure, and that when you look at the larger meta-analysis, there is no real evidence that they differ in terms of prognostic implications. There are some differences, but our position is that all of them can be used as first line, but it should be individualized. You should look at comorbidities of the patient, target organ damage, contraindications, and also possible adverse effects of drugs, and then we just individualize and target adapt the treatment to the population.
And do the ESC guidelines underscore the fact that for most patients they're probably going to require more than one pharmacotherapy?
Well, that indeed there is a discussion, should we start everybody on monotherapy or should we go to combination therapy from the start? Well, if we are in grade 1 hypertension, if patients are at low risk, it's quite possible that one drug will be enough, so we start monotherapy. But when they are at very high risk, when the blood pressure is very high, it is very likely that they need 2 or more drugs, and there we start with combination therapy.
As I said, it's been 10 years since we've had new guidelines. What was the toughest job that you had as a co-chairperson of this committee, in terms of, was there a topic that seemed to get people caught on, or was there an issue?
Well, there were not many issues, and Professor Mancia also said to others that we really agreed quite easily. Maybe there was, there's one new thing that we did, and I had to insist on that we used the classes of recommendation and the level of evidence that ESC requires. It was not done in the previous guidelines, and I'm happy that this is done now, because all the issue of the target blood pressure in diabetes, it was just said you have to go to 130 over 80. But there was no level of evidence, no class of recommendation at that time. If he had said maybe consider, there would be no problem. But now we are in a little bit of problem because now we say no, that's not true. 140 over 85 is enough. Yeah.
So now that you've got this behind you, do you foresee? I mean, you managed to get one out in 2007, and now it's 2013. Do you have a goal for the next? When are you going to start looking at it again?
Well, it depends on what will become available. Let's say in general, the European Society of Cardiology, in its recommendations for guidelines, says every 3-4 years. But we will see in 3-4 years if it will be needed. There's always a possibility to have position papers and things like that, intermediate position papers.
One last thing, the Polypill. Did you bring that up at all in terms of trying to get more people on appropriate therapy?
Well, the first thing is, what is the Polypill? There are so many possibilities of putting things in a pill, so it's very difficult to judge on a pill that you don't know what will be in that so-called Polypill. Let's say that for really our patients in Europe, that we really prefer to target the treatment to the patient.
Well, I congratulate you again for managing to get something done that we have not been able to get done. Hopefully now the ACCF and the AHA are working together, and we're going to put together something pretty soon. But until then, thank you for assisting us with this. And for Professor and for all of you, I would like to make sure that you go to ESC guidelines online. Just Google that. And you can also go to CardioSource World News, and you'll find a lot more information from the ESC meeting. I'm Rick McGuire, Executive Editor.